welcome. It's an honor and a privilege to be here today for GEMCON 2024, a not to be missed event. And I'm deeply grateful to the organizers of this conference, especially my old colleagues, Dr. Seher and Dr. Fuad, for inviting me to talk to you and share views regarding hepatocellular carcinoma, the primary liver cancer. This disease is one of the most dreaded complications of chronic liver disease in any etiology. And in recent years, we have seen emergence of therapies which now offer a ray of hope for patients who previously had a universally dismal prognosis. So I'll be sharing my views about what is new with a touch of what is old as well. There are no financial disclosures for this presentation. Now, the topic is a huge one. Whole day conferences have been dedicated to HCC, and therefore I cannot possibly cover every aspect. Hence, in the interest of time and time restraints, my talk will be focused on pathophysiology, because if we know the pathophysiology of this disease, we can clearly understand what therapeutic armamentarium is available to us and how effective it is. And then we'll go on to etiology. This is usually reversal of what we usually do. Etiology comes first, but I've deliberately placed it lower down. And then we will talk about management options, which will focus on diagnosis, screening, and then finally treatment options, which are either medical or pharmacological, help from our radiological colleagues, and finally our surgical colleagues. What I will not be discussing is analysis of the therapeutic trials and details of individual pharmacological agents, their contraindications, their dosage schedule, and the rest. That is for our oncology colleagues. And finally, I'm not going to talk about how to perform a radiological procedure or a surgical procedure. That is, again, not the topic for today's discussion. So back to some basic pathophysiology. Cancers are the result of factors which promote cancer formation, which allow it to grow uncontrolled and perpetuate, or in other words, survive. So cancer actually at a molecular level is initiated by a mutation, a damage to the DNA. As we all know that genes which are made up of DNA are the driving machinery behind all activities of the cell, including their division and proliferation and growth. So cancer basically starts when there is a change in DNA. So it's a mutated cell or a group of cells which then subsequently becomes a mass of tumor cells. And this leads on to uncontrolled cellular proliferation, loss of apoptosis, which is called programmed cell death, and I'll talk about it in a minute. Formation of new blood vessels called angiogenesis, because tumors need blood to grow, and finally tissue invasion and metastasis. Now let's look at each one of these briefly. Normal cells, as we know, they divide by the process of mitosis and they grow under the influence of growth factors, primarily the vascular endothelial growth factor, the epithelial growth factor, fibroblast growth factors, and there are other growth factors as well. These growth factors attach to the surface of what we call tyrosine kinase receptors, which in turn brings about intracellular changes, allowing the cell to divide, to proliferate, and to grow. And once the target has been achieved, the cells will go into a quiescent phase. However, this is what has been shown here. The receptor is activated by growth factors. And pay attention to this, the tyrosine kinase pathway. In the case of tumor cells of whatever origin, and HCC is no exception, cancer cells secrete their own growth factors. They become independent or autocrine. And this allows them to continue to grow, divide, uncontrolled. Now, normally, when cells achieve a certain age, they undergo what we call programmed cell death. It's apoptosis. The cells get damaged, their membranes get damaged, and they are destroyed and eaten up by the macrophages. So there's a balance normally between cell proliferation and cell death, so the cell population remains within normal limits. In case of cancer cells, the process of apoptosis, that is inhibited. There is greater degree of cell proliferation and lesser degree of apoptosis or programmed cell death, and therefore this allows the cancer to grow. So tumors also require blood. Like any other tissue, they require blood. In fact, they require more blood and more nutrients. And proteins are secreted by these tumors. For, for example, the endothelial growth factor, which allows the generation of newer blood vessels. And this stimulates not only blood vessel growth, it diverts all the nutrients from the host towards the tumor. And that is one of the reasons for man.
Thank you very much, my respected friends.
And this is what's been shown here, that endothelial growth factors allow development of new blood vessels. And this not only causes increase in the cell size and cell mass, it also allows tumors to break down the endothelial basement membrane, go into the blood vessels or lymphatic, metastasize to other parts of the body. So, ladies and gentlemen, in short, tumor cells do not obey dose signals, they generate their own dose signals. They do not obey stop signals by inhibiting anti-apoptotic factors. They promote generation of new blood vessels, which allows them to metastasize, and all in all, therefore, they become immortal. So, what is the etiology of hepatocellular carcinoma? In a nutshell, any factor which can result in liver inflammation has the potential to produce hepatocellular carcinoma. And these factors could be different. Viruses, inherited disorders like hemochromatosis, alpha-1 antitrypsin deficiency, Wilson's, porphyrias. There could be carcinogens in our diet like aflatoxins and tobacco smoking, or chemicals like vinyl chloride and arsenic. And recently, we have also realized that fatty liver disease, which has now been renamed as steatotic liver disease, whether it is metabolic dysfunction, steatotic liver disease, or alcoholic steatotic liver disease, has the propensity to form HCC. What really happens is that chronic inflammation and scarring converts a normal liver, which is a marvel of architecture and engineering, into a scarred liver, and ultimately leads to cirrhosis. And this persists for a considerable period of time. We end up with a hepatocellular carcinoma. So that, ladies and gentlemen, is the pathophysiology of HCC. How do we diagnose this? Classically speaking, with clinical features, lab tests, radiology. Do we really need biopsy? That's the question. Clinical features. Very rarely it could be asymptomatic, picked up because someone did a some unrelated. But that is very rare. Most of the time, majority of the patients are already known to suffer from chronic liver disease, and they have either decompensated or they have a sudden rise in various complications like ascites, edema, encephalopathy, bleeding, so on and so forth, and pain in the right habit. So that's how we come to an What are the lab tests? We routinely do CBC, LFTs, RFTs, etc. But the mainstay of suspicious diagnosis is based on alpha-fetoprotein, which has got a sensitivity close to 80% and specificity of liver genes. This is also complemented by another serum marker called PIPCA2. Please remember, PIPCA2 is not used as a primary diagnostic tool. It can supplement your diagnosis in using cases where alpha-fetoprotein is not found. Radiology is the mainstay of diagnosis of these DPT-4, and for that we have ultrasound, which is universally available, very cheap, non-invasive. You can do it as many number of times as possible. The downside is it is heavily operator dependent. So you need to have very experienced ultrasound to do it. Not everybody can diagnose HCC, especially if they are very small. Other two modalities are triphasic CT scan and an MRI scan, contrast enhanced. MRI is more sensitive than CT. If you look at the triphasic CT scan, this is the picture which we see with the pre-contrast before you have given the most of the time it could be a hypoechoic, faint hypoechoic area in the pre-contrast. Once the contrast has been given, in the next 25 to 30 seconds, there is a sudden blush of tumor which is called arterial enhancement. And why does it occur? Because HCC, unlike rest of the liver, is fed by hepatic artery, and the flow in hepatic artery occurs much earlier than the liver. So they stand out in about 30 or 40 seconds. Later on, the delayed venous phase, when the rest of the liver is taken up the dye as well, then they have what we call venous wash. This is the classical feature of CT. arterial
सिम आ
enhancement
गई, one of
followed
the
by
Pakistani
venous
student of KE
Okay, now who should be
is
screened?
going to get the Nobel
It's a
Prize
malignancy,
because
and
he
if we
has
can find out
invented
patients at an early stage,
a
they
chip
would be
that is
beneficial
called the
for us.
neurochip. ये पाकिस्तानी है,
Candidates for
इसके अंदर
screening
आपको
cirrhosis of
if you
any
become
etiology,
if you
whether
have
it's
become a
B, C,
conventional, आज ये वादा करें कि
or
अपने अंदर
B
अपने
plus
अंदर
D,
तब्दीली लानी
or one of those
ठीक है,
reasons which I
वही
mentioned
किताब
earlier on.
वही पुराने जमाने के
In cases of
students
hepatitis
पढ़ते
B,
हैं।
even
I think you can
non-cirrhotic
change the
patients should be
Pakistan.
screened.
I do
Why?
not think
Because we know that hepatitis B virus
मैं
gets
नहीं कहता कोई
inserted
नया
into the
चीजें
genome
हो,
of
आप
the
उस पुरानी
hepatocyte,
चीजों को
and
बेहतर
it's a
कर दें। I
pre-existing
think
condition.
ये
C doesn't do that.
आपका ऑब्जेक्टिव
For
होता
B,
है।
even
The
non-cirrhotic patients
modern
should be screened.
medical
And
graduates
then transplant candidates, the optimal timing interval is 6 months. Every 6 months they need to go screening with
कैसे आ
ultrasound.
जाते हैं ट्रांजिशन?
Easel only insists on
मैं लोधरा
ultrasound.
के
AASLD
बैकवर्ड
says
इलाके से
ultrasound
रहता हूँ।
plus alpha
लोधरा
fetoprotein,
शहर है,
especially if the alpha fetoprotein
उसका
is
एक
over
बैकवर्ड
about
इलाके में
20
रहता
or
हूँ।
40 nanomolar.
71 कंट्रीज आपको
All
पाकिस्तान
right, you have done an
दुनिया के
ultrasound.
क्या हो?
The report
दुनिया
comes back. There's
आधी
a delay.
दुनिया से ज्यादा
Now what to
लिया
do next?
मैंने
How
ममालिक
to
को
proceed?
देखा। ठीक है,
Look
आप
at
कहने
the
का मतलब
size
है
of
कि
the lesion.
you invent
If
yourself.
the size is
मैं
less
भी
than 1
बेसिक
centimeter
मेडिकल
and
साइंसेज
alpha
से ताल्लुक
fetoprotein is
रखता हूँ,
normal,
लेकिन मैं
follow this
पाकिस्तान के
patient
सारे
every 3
हायर
months with an
ओथों पे
ultrasound
रहा हूँ। अपने
plus
आप को
minus
इस मकाम पे लें
alpha
कि
fetoprotein.
लोग
If the
खुदी के
size
ऊपर
remains
बुलंद इतना
unchanged
कि
for a
हर
year,
तकदीर
then you
से
can
पहले
fall back
खुदा
onto
बंदे
6
खुद
month basis surveillance.
बता तेरी रजा।
If,
लोग मेरे
however, the
इंटरव्यू
size
लेते थे जब
increases
मैं बैठता था
or
इस
alpha
जगह पे
fetoprotein goes
तो
up,
दिस
or
एक्चुअली द नॉलेज
the
इज
last
नॉट स्टडी
ultrasound doctor
एक्चुअली
shows
जो
there is
ये जो
vascularity,
ये
then you go on to the protocol for
आपकी
lesions
इंटेलिजेंस है
more
जो
than
अल्लाह
1
ताला
centimeter.
ने आपको कर दी है
So
उसका
size of the lesion is 1 centimeter.
आपको
The
इस्तेमाल
next
नहीं
step is either use a
करने
CT
तो ज्यादा
or an MRI
और
contrast
ये
enhanced.
आर्टिफिशियल है
And if you
जो
find typical
कंप्यूटराइज
radiology, which I just
नॉलेज है वो
mentioned
आपको
earlier
दिया
on,
जा रहा है
arterial
ना
blush and
कंप्यूटर
venous
खोलता है ना
wash
रखता है
you have established the
ना
diagnosis.
उसको
That's
खुराक
easy.
चाहिए ना
Proceed
उसको
to
पानी
management.
चाहिए
If
ना वो
not,
गलती करता है
then
ना कुछ
in
करता है
step
लेकिन आप
2,
हमेशा
use the modality
कंप्यूटर
of
किसने इजाद किया
imaging which was
तो
not used in
लेट्स
step
सी
1.
कि
In
व्हाट
other
इज
words,
अब
if
ये
step
पुराने
1 used
जमाने में
CT,
पढ़ाया
go
जाता था
for MRI now. If
डॉक्टर
step
सहरा
1
ने
used
एक
MRI,
बहुत
go
सारी
for
आपको
CT.
एग्जांपल दी
If
कि
now you
एक
again find
पेशेंट
typical
का
features,
एग्जांपल
you have established the
अब
diagnosis.
उसमें
If
से मैं
not,
हाल डॉक्टर
then
आयशा
biopsy is
या
needed.
एक और स्टूडेंट के
The
अलावा
important thing is,
चंद लोगों ने
in a
बताया
cirrhotic
कि इसके
liver,
आगे क्या जाना है तो आप देखें इतने सारे
biopsy
हम
may
लोग
not
करते
be
हैं
needed
कि
for
ये
every
हमारे
case.
अंदर नॉलेज है
A typical
हमें
picture
वही पुराने
on
जमाने की
CT
किताबें
or
पढ़ के
MRI
वो
establishes the
प्रैक्टिस
diagnosis.
करूंगा या वो करेंगे तो हम कहना
But please remember, if you find an SOL in a non-cirrhotic liver,
आप आज
don't
घरों में
depend on
आपके
imaging
तमाम
study
फ्यूचर
alone.
स्किल में
Over there, a
सोचें
biopsy is
हम
mandatory because intrahepatic HCC
मेरे पास आर्टिफिशियल
plus cholangiocarcinoma can
एक
produce a
मशीन
similar picture.
लर्निंग है
The management is
जिसको
different.
डाटा जनरेट करता
What are the
और एक
treatment
डीप
options?
लर्निंग है
We have
उसके
medical,
अंदर
which is
जो मैं
pharmacotherapy.
आपको बताऊं
We have radiological
मेरे पास
procedures and
टाइम
surgical
नहीं कि मैं
procedures.
प्रैक्टिकली आपको
It is
दिखाता कि डीप लर्निंग
easier to
कैसे कर
classify
सकते
them
हैं और आप
treatment
मशीन
based on a
लर्निंग कैसे
curative
कर
or a
सकते हैं
non-curative
ये
intent.
साथ
That
ऐसा
makes
होता है जो
things
कुछ पढ़ते
simplified for us.
हैं ये एक एग्जांपल
Curative treatments
कि
are,
इस
as you can see
आर्टिफिशियल
here,
इंटेलिजेंस में और पुराने
ablation,
जमाने की
resection, and transplant. The last
जैसे
two are in the
एग्जांपल
domains of
डॉक्टर सायरा
surgeons.
ने दी
The first one is
उस
in the
तरह के ये
domain of
देखें कि एक
either
एग्जांपल है कि
hepatologists
व्हाट इज द
or
डिफरेंस
preferably
ऑफ
interventional
ओल्डर टीचिंग
radiology.
एंड न्यू टीचिंग
And
कि
ablation
पहले
using
जमाने में ये
either
था कि बंदा
radio
कंफ्यूज खड़ा
frequency
है
ablation or microwave is
पीछे कैसे
reserved for candidates whose lesion
बेटा
is
ये
between
इसका
2 to 3 centimeters,
आगे
not more
चला
than 3
ये
centimeters.
कोई वाली
They are
स्लाइड
not surgical candidates otherwise, and the location is easily accessible. They can survive for
ये पीछे
5 years for as much as 65 to 70%. Resection, patient should not be cirrhotic or at the most child class A cirrhotic. There should be no clinically significant portal hypertension, and it should be a solid
अब देखिए बेटा ये
mass.
एक स्टूडेंट
And
खड़ा
it is
है और
important
साथ का
that
टीचर
post resection there should be enough liver remnant to
आपसे
support
ज्यादा
life.
अहम
Transplant would be the
ठीक है
ideal
उस्ताद क्या
candidate
है
when
बाप से
cirrhosis
ज्यादा
is so far
क्योंकि
advanced,
उस्ताद ये चाहता है कि मेरा
and
स्टूडेंट मुझसे आगे
it should be within Milan
सिर्फ
criteria.
बाप ही
I will not talk about that. That's for our
ये
surgical colleagues.
इससे
What are
कैसे
Milan criteria? What are
के
extended?
स्टूडेंट
In each of these
उसके
three,
साथ
the
ये
survivor
जो
can
आप
be for
artificial
70 to 80%
intelligence
in the next
आप
5 years. So
54
these are the
तक
curative treatments. There's
Continuous
another curative
learning है
treatment, intrarenal
ट्रांसफर ऑफ
ethanol
स्किल है
injection, but I have not
सारी सिमुलेशन लेके
mentioned it
एनाटॉमी की
because
आपको
it's no
दी
longer recommended.
सारे
What
पैथोलॉजी
about
की स्लाइड्स अभी
non-curative?
मेरा ख्याल है एक
Non-curative
स्लाइड मुझे
means you're not curing the disease. It's there, you're only controlling it.
मैं अभी
We
डालता
have
हूँ अभी
TACE,
आपको
which is
डायग्नोस
trans-arterial chemoembolization or
फिर आप ये
monoaspiration,
क्या
DEB TACE, where
अभी
along
हम
with
अपने
chemoembolization, add doxorubicin or epirubicin to the procedure. There should be no portal vein thrombosis. Why? Because you're going to approach it through the hepatic artery. If the portal vein is already thrombosed and you inject the material into hepatic artery, you thrombose that as well, you lose the patient. Class A or early class B cirrhotics, and there should be no extrahepatic meds.